Okay. Okay. Just by way of introductions, my name is Dr. Chang. I trained at Loma Linda for radiology, and was back and forth to Boston and then came back. And so happy to do this. What to to kind of facilitate, I'm going to be asking some questions, and so you can use your Zoom group chat, and I'll see that. And so don't be afraid to answer. If you answer the same as the person before you, just answer it again. That's fine. Just so I know that you're alive, I guess. And if you don't, also be afraid to deviate from what the answer has been before if you think it's something else. This is obviously, we're not keeping score or anything like that, and we're here to learn. So the first, let's see if this works. It says meeting audio may not be fully recording.
Oh, don't worry about it.
Okay. Okay.
So, to advance, you go here, and then how do you make this dot go away? Oh, here.
Okay. So just find this here.
Or you
Okay.
can just click in the block anywhere.
Oh, I can't do that. Okay. All right. That's fine. Okay. So this first lecture is on indications. Basically, I think my philosophy for you guys is, I'm not trying to train you to be a radiologist. I know that most of you won't be, and so I think that it's more important for you to know, like, how do you use radiology in whatever surgery or medicine or whatever specialty you go into. So indications is all about, okay, I have a given indication, what test do I order? Okay, and you may already know what test to order just based on experience. Your attending or your resident told you to order this or that, but I think I want to emphasize, like, why is this study better than this? Okay. Okay, so caveats to this lecture. The best study for any given indication can and will change over time. So I'm telling you, try to be current, but as long as you understand the principles, and obviously new technology will change the way we image. Okay, your specific indication or your patient situation may be atypical. So you may have a choice imaging, first-line imaging that you would do, but your patient situation, patient has renal failure, patient has an allergy to contrast, and it may make your first choice not available. So what do you do in case of that? Okay, and so the main point is that you're not going to know every imaging test, what to order in every situation, and I think for you to call the radiologist, I think we would rather get a call if you are unsure about the patient, and obviously not for simple things where you've checked, let's say you're attending or your resident doesn't know, then I think it's better to call the radiologist to ask what is the best test. We'd rather do that than you order a test and it's the wrong test, we do it, find out it's not the best test. Okay, and so the principles of imaging are important. So when you think about what you're going to image, I think key thing to think about is think about the main modalities. Okay, so X-ray, ultrasound, CT, MRI, and I've thrown in fluoroscopy, nuclear medicine, and IR. So I tell this to my kids when they were learning math, is that, when they were doing word problems, like, I asked them, is this an addition problem, subtraction, multiplication, or division? And they would usually be able to figure it out. Okay, so when you think about an indication, start from the basics. Is this best test is an X-ray, ultrasound, CT, MRI? Fluoroscopy we'll see, is for GI purposes and other things, but usually less. Nuclear medicine, we'll do a few cases, and then IR, mainly for procedural, interventional type stuff. Okay, so but if you think about that in terms of which is the best imaging and why, and I think you'll get the main principles. Okay, and so not all the indications I present here need imaging. Okay, so no, it advances, but it doesn't do the animation stuff. It's fine. I think today we'll just go through it.
Okay.
Okay.
Sorry.
Okay. No problem. Okay.
I transferred it to the file.
Okay, so the first thing we'll start with brain imaging. All acute cerebral indications. The answer is there. I'm sorry, but it's basically a head CT without contrast. Okay, and I think you probably know that. Let me do this. So could I switch to the other format?
Yeah.
Okay.
PowerPoint, right?
Yeah.
Just tell him to shout out the question because they can't.
Okay. So instead of using the chat box, you can just turn on your microphone and then shout out.
Because the Google, we're not going to be able to see their.
Yeah.
You guys see the screen? Better. Oh, it's okay.
Well, we'll see. Hey, can someone type in something to make sure the chat is still working? Okay.
Cool.
Okay. Thank you. Okay, so it's still working. I can see it.
Oh, they don't see the chat box. You do.
Oh, I see it. Okay. So, yeah, throw in your answers. So the first one's give me a head CT without contrast. And the reason for it is that it's fast, it's available in pretty much all hospitals, and this is head CT without contrast is for acute things. Probably better than MRI for at least the speed of it for blood, skull fractures, everything that you need acutely. So the mainstay imaging for ER is really the CT. Okay, so what indications do you need a head CT with contrast? I won't ask you to answer that, but basically, if you think about contrast, anything that takes up contrast, and we'll go into what contrast is, and I'll show you pictures. Infection and tumor. Okay, so if you're looking for infection, tumor, you want to consider with contrast. Okay, and actually, in fact, a better study would be an MRI with and without contrast, and I'll show you pictures of that. Okay, so here is a head CT without contrast, and this, I don't know if you can see my arrow, this area I'm pointing to, the bright white area is a bleed. That's hemorrhage, acute hemorrhage. That's in the left basal ganglia. This is most likely a hypertensive bleed. And so on contrast, fast, it takes a few seconds. People in the CT scanner for a few seconds, and you have your answer. Okay, so here's another non-contrast head CT. Okay, and it shows in this area in the right basal ganglia a dark area, and what that is edema. Okay, and the cause of that we don't know yet. Is that an infarct? Is there an underlying mass? Is that infection? We don't know. Okay, so here is where contrast can help you. Okay, and notice that because there's edema, it has mass effect and it narrows this right lateral ventricle here. Okay, so this is a MRI and of the same patient, and this is a fluid sensitive sequence. So anything that's bright is usually fluid or edema. So this right basal ganglia, there's edema. So basically it shows the same thing. We get the same information. Okay. So now we add contrast. Okay. So contrast, anything that enhances is going to be bright. Okay. So within the center area of this edema right here, there's this enhancing kind of ring-like lesion. Okay. Underlying mass. Okay. Whether this is infection or tumor. We now know the cause of this edema. It's not infarct. There's an underlying, probably a tumor right here. Okay. So that enhancement brings out what that tumor is. Okay. Okay, the indications here is for hearing loss. Okay, and what did I say? Asymmetric hearing loss. What thing, kind of classic thing, are you trying to exclude by imaging? I'll wait for this answer. Chat. Asymmetric sensor, no. Tumor. Okay, is there a specific type of tumor? Okay. Vestibular schwannoma. That's correct. So of one of the cranial nerves. Okay. Okay, and so the way to image how would you image that? And I've already given you a hint. And you can go down the question: is it X-ray? Probably not. CT, ultrasound. Ultrasound's not going to be able to penetrate the skull for the most part. CT or MRI. Okay, and I have an answer of. Let's see. Let me get a few more answers. MRI. Okay, so pretty good. Just like on the last case I showed you, MRI really is a study of choice, and you can get a specific type of MRI of the internal auditory canals with and without contrast. And I'll show you a case. So this is without contrast. Okay, this is an axial. This is a fluid-sensitive sequence, a T2, and this is bright. Okay, and so this is a normal right internal auditory canal. You can actually see a cranial nerve 7 and 8 right here. It goes to the cochlea, semicircular canals here. And on the left side, you see this thing, this dark thing that blocks. This is a tumor. This is a vestibular schwannoma. Okay, and it's obviously involving the cranial nerves there. That's why you have hearing loss. And when you give contrast, this tumor enhances. That's on the axial, and this is on the coronal sequence. Okay, so MRI gives nice contrast, and you can see the tumor and have the diagnosis with that. Okay. Indications, I can't really see my own screen, but it says amenorrhea and galactorrhea. Okay, found with elevated prolactin levels. What are you trying to, what diagnosis or pituitary adenoma, correct? Okay, great, thank you. Okay, adenoma. So what's your radiologic study of choice? What do you order? Okay. Okay, pretty easy. We're just starting off pretty easy. MRI, really your main stage of imaging, and this is a focused MRI of the sella turcica, or the pituitary with and without contrast. And here is a sagittal view, basically a sideways view like that. See the nose, and this is the brainstem. Here's the pituitary, and here's the optic chiasm. Okay, and when you give contrast, the pituitary tumor is actually hypoenhancing. It's actually darker relative to the normal pituitary, so it's right there. Okay, and this is a normal pituitary with a pituitary stalk and the optic chiasm. You can see that if a pituitary macroadenoma comes up and it's bigger, it would compress on the optic chiasm, giving you the bitemporal hemianopsia that you're classically familiar with. Okay. Okay, moving on. Neurovascular imaging. Okay, so to evaluate intracranial aneurysms, stenoses, vascular malformations, what are your options? Now, there's more than one answer, so probably all of you will get one of the answers. So let's see what you suggest. Okay, CT angio, MRA, good, MR with contrast. Okay, all good answers. Okay, so let's go through the kind of progression again. Obviously, it's not going to be X-ray. Ultrasound again, we're not going to penetrate the skull. CT angio specifically, where we evaluate the vessels. That's a very good option. Okay, MR angiogram, also a great option. And another way, a more conventional way that you don't think about per se. One can think about that. This is in fact almost a gold standard. I know we're used to CT or MRI, but anyone can guess that. Okay, it's conventional cerebral angiogram, and that's an IR procedure. Basically, interventional radiology would stick a vessel in the groin, feed up a tube and wires up to the aortic arch, select one of the carotid vessels, and inject that vessel directly, and they would image the resulting angiography. And so this is historically the gold standard. You can treat, if they see an aneurysm, they can start treating it right away. Obviously, it's a procedure risk, okay? And so, but most of the time, we don't start off that way. the interventional radiologists want to know what they're treating. So to diagnose it, I think CTA of the head is probably the new gold standard. You want to see it before they, interventional plans to do anything. Okay, and I'll show you pictures from that. Okay, and like you guys suggested, MR angiogram also can be done. It can be done with contrast, but it also can be done without contrast, and I'll show you images for that. That takes the count of flow, signal flow, and I'll show you how the images turn out. Okay, so this is a conventional cerebroangiogram. They're actually shooting carotid, and this is the vertebral system, and basically they inject the dye into one of the arteries, and then they time capture these images here. Okay, so pretty good detail. You can see aneurysms if you did this. Okay, so this is an MRA brain. So this is all done without contrast, believe it or not. Okay, you can see the vessels. You can see a 3D projection of it, the carotid. These are the two vertebral arteries, the basilar artery. Okay, and actually here is the aneurysm here, and you could do a 3D rotation of that. Your aneurysm is right here. Okay, go back and forth. Okay. And this is all done without contrast. So in case you couldn't use contrast for some reason, you have an MRA without contrast to be done, taking account of flow signal. Okay, so how would you screen for selected carotid stenosis in the neck? Let's open it up again. Anything, so I think CT, MRA, okay, is given. Okay, and the only other addition I would say is, you're correct, ultrasound. Okay. Ultrasound, there's obviously no bone blocking your view of the carotid arteries. Okay, so ultrasound is cheap, it's easy. It's kind of the standard criteria for decision making in terms of whether or not to do a carotid endarterectomy. There's verified, validated numbers, velocity measurements, and I'll show you that. CTA is more expensive, better resolution. It can capture whether the stenosis is 99% occluded versus if it's totally occluded. Sometimes the ultrasound doesn't have that sort of resolution. Okay, and it's bad. Again, a common theme for CTA or CTs in general is that for trauma or dissection, you want to see it in detail to see. Sometimes the dissection flap is really small, and you want to be able to see it well in a CT. Okay, again, you can use an MRA. The benefit, another benefit of MRA besides be able to done without contrast is that sometimes people are getting an MRI brain to rule out stroke, things like that, and they want to attach an MRA to it. An MRA study, pretty quick, 10-15 minutes, you can just attach it to the MRI. So that's more of a convenience, just do it all at the same time. You can get an MRA of the neck, head, and then an MRI of the brain. Conventional angiogram, again, you can shoot dye directly. Usually it's reserved for when you're actually going to do the procedure. You're going to stent the carotid stenosis, and they're going to shoot an angiogram just to make sure the stenosis is there, and then and then do the procedure. Okay. And I can't quite see that. That's fine. Okay, carotid ultrasound. If you look at this, the red meaning it's going down. This is a key. The blue is going up. Okay, so this is a vein going down. This is the artery going up towards the head. Okay, and then we put our waveform analysis. It has an arterial waveform, and it measures all these different things like peak systolic velocity and decile velocity. You don't have to know all these numbers, okay? But there are validated numbers to assess the degree of stenosis based on velocity measurements. Okay, so yeah, so if you're screening for stenoses as an outpatient workup, ultrasound is a good test. Okay. Okay, so let's talk more about just ultrasound in general. Okay, so ultrasound, the advantages are it's real-time scanning. Basically, the sonographer is placing the probe. Hopefully, you've all seen that, and you can see vessels, the flow in real time. You can move it all around, and you're watching it as in real time. Okay, there's no ionizing radiation, so you can spend as long time as you need to. You're not going to hurt the patient. lower cost. When I say lower cost, it's relatively less expensive, but even this machine is probably $200,000. Even this portable that you can bring wherever, probably $40,000-$50,000. But it's going to be cheaper than installing a CT or an MRI. Okay, this is very accessible. Can be performed portably. You can see you can roll it up to inpatients at the bedside. Patient doesn't have to come out to the radiology department. And we talked about validated velocity measurements. Disadvantages, operator dependent. It's a sonographer who is looking for abnormality. If he or she does not see the abnormality as a radiologist, can't make that diagnosis. So we're dependent on them to do a good job, scan, and look for what they're supposed to look for. Okay. The other thing is that ultrasound waves, it's based on sound waves. It cannot penetrate air or bone. Okay. So bone we kind of understand, but also air. I'll show you why. Air, bile gas, it basically negates the sound waves. So you can't penetrate that. Okay. Poor penetration for larger patients. So, I'll get studies where they're ordered. They want to look at the pancreas, which, as you know, is the central structure on, let's say, a 300-pound patient. Well, I'm not going to be able to see that because it's really deep inside the patient. A large patient, poor sound wave penetration. So it's limited in that regard. Okay. Poor technique can alter the velocity measurements, like I showed you for the carotid. It's very important for the technique. They can throw the velocity measurements in all sorts of different weird numbers that don't make sense or are inaccurate, so they have to pay attention to technique. Okay, so here is a CT angiogram of the neck. You can see the vessels here. This is carotid. These are the vertebral arteries. Obviously, the carotid is not surrounded by bone. You can put an ultrasound. Right here, you can see the carotid. Vertebrals are harder to see because they're surrounded by the transverse processes. But in between these spaces, you can see the vertebral arteries. So you can see it, but it's not going to be good for dissection, stenoses, occlusions. On the other hand, carotids, they're pretty well visible by ultrasound. Okay, you can also do a MR venogram. So this is not an MR angiogram. This is venogram. This is of the veins, draining veins in the head. So this is the superior sagittal sinus, okay, and different projections of it. Okay, and so when you order it, make sure you're not ordering an MR or CTA. That's angiogram. Everyone, I've had even attendings mistake it and think, okay, angiogram means a vessel, which yes, but it's more referring to the arterial vessels. Venogram, it's a different study. Okay, you can also do a CT venogram. Obviously, you would need contrast with that. This MR happens to be done without contrast, taking for the flow phenomenon, and venogram, CT venogram, you would need contrast. Okay, let's move on to spine imaging. Okay, so this is the question for you guys. 50-year-old with 6 months of back pain, radiating to the left leg with decreased sensation over the left leg. He's tried all sorts of conservative therapy, everything you can think of, but doesn't help. Okay, what study do you order? Okay. Okay. Okay, great. Okay, good. So most of you said MRI. Someone said CT, which is actually, I'll show you so I want to show you the differences. Okay. The best test, you're correct, is an MRI of the spine. Okay, so just to orient you again, this is a sagittal view like this. Okay, this is the spine. This is the vertebral bodies, the discs here. This is a normal disc. This is the spinal canal with the CSF fluid. This is your spinal cord, and these are the caudate equina nerve roots here. Okay, so this is an abnormal disc where it's protruded back into the spinal canal. Pretty big protrusion here. Okay, and this is an axial of that. Okay, we'll scroll through it, and this is the vertebral body. Okay, this is the spinal canal with the nerve roots right here. Okay. And here is a disc bulge or disc protrusion right here. As I scroll down, it's pretty big and it's blocking mass effect on these nerve roots. These nerve roots are pushed back. Usually they go out, exit the neuroforamina here. This is blocking the entrance of the neuroforamina. Okay, so let's compare CT versus MRI. You've already seen the MRI. This is the CT. The same patient at that same level. You can see there is some sort of disc bulge right here. I don't know. Are you able to see my arrows? Maybe. Yes. Oh, great. Okay. Yes. Okay. You see this little disc bulge, this bright area right here, narrowing the spinal canal. It's tough to see it on this axial. Okay, so that's why MRI is going to be superior to CT based on soft tissue contrast. If you look at the CT just in general, you'll notice basically three types of density. Okay, there's fat density, this black. Okay, there's soft tissue density here, this grayish, and this bone, this white density here. Basically three different densities. On MRI, it's much more. There's different contrast based on fat, bone, disc, CSF, nerve roots. You can just see that there's much better contrast and you can see structures better. Okay, CT versus MRI. So like I said, MRI is much better evaluating the soft tissues, discs, spinal stenoses, spinal cords, looking for discitis, osteomyelitis, epidural lesions, metastases. CT is mainly in the spine, is mainly for trauma. Okay, like again, I'm repeating the same thing. It has better bone detail or better resolution. It's faster, it's more available, quick. A CT scan takes a few seconds, and an MRI, you may be in the scanner for 30 minutes. And that's not going to be as helpful in the trauma situation. Okay, so here is a Jefferson burst fracture. This is the ring of C1. This is the odontoid, where it goes like this, where your head swivels on, and it's basically that fracture. It's burst. That ring is, that's why it's called a Jefferson burst fracture. Okay, and CT mainly used for trauma. Okay, let's move on to MSK imaging. Okay, by the way, if you have a question, feel free to just put it on the chat. I might not acknowledge it at that point, but I will get to it. Okay. So CT can sometimes be helpful in diagnosing occult fractures. So this is of the wrist, carpal bones. You can't see the fracture here on X-ray. That's why I'm showing it to you. But they were very suspicious for that. We got a CT, and you can see fractures in the carpal bones. And let's just scroll through it. Okay, and you see at the bases of the metacarpals, a fracture there, fracture here. It's pretty comminuted here. Right here, all these little bone fragments here. On the X-ray, even in retrospect, you cannot see that. Okay, so CT is really good for fine detail of the bone. Again, it has better resolution, and you can see the detail of the fractures. Okay, and so CTs are sometimes used for surgical planning. Obviously, this is an X-ray of the shoulder, and there's a fracture. It's a comminuted fracture. You don't really need anything but an X-ray to show you that it's a fracture. But CT can be used when orthopedics wants to plan their surgery. Okay, and so you could do a CT rendering of 3D rendering of that fracture, and you could basically look at that fracture at all different angles, and it helps for the surgeon to plan their approach. Okay. CT again, MRI. MRI is better at evaluating soft tissue structures. CT is better for osseous detail, has greater resolution. I'm trying to emphasize that. You might get that on a test, but that's for that. So common MSK exams, and you know this. These are the common joints that you're going to get an MRI for, and it evaluates the soft tissue structure as well. Okay, and so I just wanted to show you something. Obviously, you don't need to know how to diagnose these. This is MRI knee. Okay, this is again a sagittal view of that. Okay, and this is the femur. This is the tibia, patella right here. These little black triangles are the meniscus. And in this meniscus, this posterior horn of this meniscus, there's a bright linear signal through it, and that's a meniscal tear. Okay? This is a normal PCL. There's a band that connects the two. Okay, And where the ACL is supposed to be, it's supposed to be that same pretty black thing. Basically, it's ripped. Okay, so this is a full thickness ACL tear. So again, MRI is good for soft tissue structures, and it can diagnose meniscal tears, ACL tears. Okay, I think you guys know that. Okay, so other indications for MSK imaging: prostate cancer, evaluating for osseous mets. What can you order that covers the whole skeleton? Okay, so now you can answer. Think from the X-ray, ultrasound, CT, MRI, nuclear medicine. Okay, so good, good, good. A lot of you said bone scan. Okay, which is good. That's the correct answer. Okay, and cancers that are not well detected. And so I'll show you what a bone scan is. That's a nuclear medicine test. Cancers that are not historically well detected are multiple myeloma and eosinophilic granuloma or histiocytosis X. Those you classically get an X-ray survey, basically of all the skeleton. And if you think about it, if you want to evaluate the whole skeleton, if you were to do CT, I mean, that's the whole from top to bottom. That's a lot of radiation. Not that if you're thinking cancer, radiation is not as a big a deal, but, or an MRI, think about scanning the whole body. There are people who do that, but it's, it's an expensive test. It takes a long time. Ultrasound, you're not going to do it. X-ray, you could X-ray every single part of your, okay, and you do that for multiple myeloma. But bone scan is kind of a one test that covers everything. Okay, so this is a bone scan. So what nuclear medicine test is they inject a radionucleotide in your veins, and it circulates through your system, and we have different tracers that go to different sites of the body. So in this case, a bone scan, the tracer wants to go to bone, hence bone scan. And so it goes to, and the parts where it lights up more, these bright areas right here, are where there is active bone remodeling. So here in the ribs, okay, here in the spine, in the pelvis, and that's in the bladder because the radionucleotide is excreted at the renal system. This is degenerative change of the knee. Okay, so, but there's enough spots here, multiple spots, think this is compatible with metastatic disease. Okay, this is just another view of the same patient, just black and white. Okay. So let's talk about nuclear medicine. Okay, nuclear medicine, unlike all the other modalities where, let's say CT or X-ray, we're shooting X-ray through the patient, and depending on how things are blocking the X-ray, we have an image. Nuclear medicine, we're injecting the radioactivity into the patient, and the radioactivity is emanating from their body, and the radiation is captured by these scanners. Okay, so here is a PET CT. Okay, and I'll show you the advantages of nuclear medicine is that it's functional or metabolic imaging. It shows activity based on your metabolism, okay, rather than anatomic imaging. And I'll show you what that means. It can, you notice in this middle picture, this is the PET portion of this PET CT. It shows the activity in the brain, in the kidneys, spine, different areas, okay? But you notice the anatomic resolution is not great. And like, where is that? I'm not really sure, okay? And here is where we can combine anatomic imaging, as in this CT. We can overlay the metabolic imaging on top of the CT, and you get this fused image. So now I can see, okay, well, that's where the heart is, that's kidney, I still don't know what that is, but you can fuse that to get both metabolic imaging and anatomic imaging. Okay. Disadvantages is for nuclear medicine, if you just did the nuclear medicine portion, low resolution, like I said. It's expensive. It requires a length of time to acquire the images, so you have to inject and you have to wait for the tracer to accumulate. This is not a 10-minute exam. You wait for the tracer to accumulate and then you image it. It may take from injection to imaging a few hours. Some exams take over the course of a few days. Okay, so, and then also radiation to the whole body. Okay, the tracer that you inject goes through the whole body. Okay, and so there's activity that radiation to the rest of your body. You're not just focused on one area. Okay, other indications for MSK imaging? Okay, so a question for you guys. 75-year-old female, status post-fall, hip pain, can't weight bear, x-ray was negative. You still suspect a fracture. What's the best test, the test that has the best sensitivity for occult hip fractures? Okay, okay. Okay, good. So I have a mixed bag of CT and MRI. Okay, good. So MRI is the most sensitive test in this case, and I'll show you why. Okay, not that MRI, CT is not good, but I'll show you. Okay, bone scan. Not many people do it, but just to throw it in, as we think about all the different modalities. Yes, we start with X-ray. If we see it by X-ray, there's no question. Okay. Bone scan, it's increasingly sensitive the longer you wait. Okay, so 80% of fractures visualized the first 24 hours after trauma, and the percentage increases. But how many are you comfortable with missing 20% of fractures within 24 hours? Okay, that's not a good scan. Okay, so CT is also for finding little combination or little fractures for surgical planning, and maybe CT is the only modality available after hours. Say midnight, let's say MRI is not available, while your only real choice is CT then. Okay, so this is the X-ray of that patient. Okay, and we can't really see, this is the femoral head, femur, and we don't, I mean, this white thing is actually the patient's, how should I say, pannus. It's kind of overhanging all the bone. You can't really see the bone really well, but we notice this little lucent thing here, the greater trochanter. I can't say for sure whether that's a fracture or not. Okay, so let's say they got a CT. Okay, well, they got the CT, and okay, there's that lucent thing here, but you notice that the cortex is really wavy. That's because the patient moved. You can imagine the patient moved and the bone is wavy. So is this, is that motion here, or is that a nutrient foramen that's not a fracture? There's enough doubt, for that. Okay, so it moved on. Patient actually got a bone scan. Okay, so you did a bone scan. This is the right hip, left hip. There's no increased activity there. Does that mean there's not a fracture? Okay, the bone scan was performed 20 hours after trauma. It's read as negative. Again, can it miss a fracture? Yeah, we know that. Okay, so they finally got an MRI. Okay, so this is, normally this is not a test case. This is not what you should be doing, but this case I illustrate because it shows all the different modalities. Okay, so here's an MRI. Here is the femoral head. Okay, and on this fluid sensitive sequence, this is the edema of the fracture. Okay, and over here, I don't know if you can see that. Okay, right here, this black line through the intertrochanteric region is your fracture. Okay, so no question, this is an intertrochanteric fracture, non-displaced, but MRI shows it very nicely. Okay, again, MRI is good for soft tissue structure, or not just soft tissue, but it has better soft tissue contrast. Okay, so so MRI is your test of choice, and again, that might be a question. Okay. Diabetic with ulcer, plantar, the left foot, concern for osteomyelitis. What's the first test you would order? Okay. Okay. Right, a few of you answered X-ray. Let's start with X-ray, because if there's underlying erosion, periosteal reactions, changes in the bone, and you can see it, well, you've solved the problem with a pretty quick, inexpensive test. Okay, so here's an X-ray of the foot. Okay, and you can see the soft tissue ulcer on the plantar aspect of the forefoot, and it's close to the bone here. But looking at the bone, you can't really say. It's pretty much read as negative. I don't see any erosion, no definite signs of osteomyelitis. But the patient had a Y count, elevated ESR, things like that, and they still suspected osteomyelitis. Okay, so does this rule out osteo? I think you can know the answer is no. Okay. Okay, so they did a bone scan. Okay, so bone scan again is metabolic functional imaging, and this is the left foot at the side of the ulcer, and it's this this bright spot is right where the ulcer was, and this is diagnostic of osteomyelitis. Okay, so we know patient has osteomyelitis. The bone is actively turning over right here. Okay, and it corresponds to the site where you suspect it. This is osteomyelitis. Now, again, it's not anatomic imaging. Do I know it's not involving the metatarsals? Is it which bone exactly are the surgeons going to go after? Okay, so here is where, okay, CT, we had a question, why not CT? Okay, that's a good question. Okay, CT can also show erosions, but it's still limited in the fact that you have to have erosions. Okay, sometimes it's just edema, it hasn't eroded the bone yet, and that's why even bone scan can show the functional status. Okay, but the best test is actually MRI, and you can see the edema, and actually this is an cut through the bone, and this is one of the sesamoid bones. Okay, you can actually see the erosion, subtle erosion, but it's brighter than all the dark bone here. Okay, and if you give contrast, that little sesamoid bone enhances. Okay, and so it's actually osteomyelitis of that small little sesamoid bone, not actually involving the metatarsal. That's where the osteomyelitis is. So MRI gives exquisite detail and soft tissue contrast. Okay, so this is enough for the surgeon to, if they were going to operate or decide to treat with antibiotics. Okay. Okay, and you also get soft tissue detail. There's enhancement all around the soft tissue that you suspect. There's enhancement of the muscle, myositis, cellulitis, everything, as well as the osteomyelitis. Okay, so when you're ordering an MRI of the foot, one thing you can be aware of is that you want to be as specific as you can when suspecting osteo. So I get these orders that scan the left foot. Okay, well, the bones of the foot are really, if you scan the whole foot, you lose the detail. You want to focus on the area of interest. So in this case, you're not sure. Let's say just say it's in the forefoot or it's in the midfoot or the hindfoot. That way we can focus on it, give you better detail. Look, I mean, we're looking at a little sesamoid bone. So if you scan the whole foot, I might miss that. So you want to give detail on where the ulcer is or where you think the osteomyelitis is. Okay, let's move on to thoracic imaging. Okay, shortness of breath, tachycardia, and again, I'm letting you give an answer. What diagnosis are you thinking about? What do you order first? Okay, good, good. So a lot of you said PE, pulmonary embolism, good. Okay, and CTangio, correct. Okay, except, my first point is get a chest x-ray first. And there may be other causes of shortness of breath. Maybe there's a big pneumonia and you solve the question with an x-ray. So kind of a trick question, kind of trick myself too, but the order of the first test, get a chest x-ray, very easy. Okay. If it's negative, you still suspect PE, then what test? And I think you've said it, a CT angio of the chest or PE. Okay, and we'll talk about VQ scanning. Most of the time we're not doing that anymore, but it's another option. Okay, I just want to mention briefly about D-dimer. D-dimer, probably you already know that it's a good negative predictive value. In a low-risk patient, you get a D-dimer and it's negative, then the chances of you having a PE is almost nil. Okay, and so then it avoids getting the radiation, waiting for a test, a chest CT, whatnot. Okay. So here is a CT for pulmonary embolism, and we scan during a phase of contrast where the contrast lights up the pulmonary arteries. Okay, and so if we scroll through, this is the main pulmonary artery, right branch, left branch, and this dark area is the pulmonary embolism, the filling defect. On the right, there's another pulmonary embolism there as well. Okay, scroll through, pretty extensive pulmonary emboli. Going now into the branches of the pulmonary arteries, okay, both sides. Okay, this is obviously an emergency. Okay, and so that's kind of the CTA for PE. That's pretty much scan of choice in the ER. It's fast, just like with all other CTs. It's fast. VQ scanning, let's say the patient could not get contrast, had a severe allergy to contrast, okay, can't get the patient almost died last time they got a contrast, so you can't use the contrast. Well, what's your option? You can't do a non-contrast CT. Well, VQ is another option. Okay, VQ scan, not that you know how to read it, just briefly, this is a ventilation image where the patient has a mask and they're breathing in radioactivity and it's circulating through diffusing through the lungs. This is the perfusion scan where they inject a radioactive dye through your veins, and this is the area of the lungs that are being perfused, and you're just trying to see a mismatch. Again, I don't want to spend too much time, but it's a much more involved study. It takes longer, and again, this is a functional imaging, not so much anatomic. That's why you have to have a chest x-ray prior to a VQ scan. The reason is if you see an abnormality, a diffuse abnormality on chest x-ray, it may make the VQ scan, you may not be able to interpret the VQ scan correctly. Okay, so again, start with the chest x-ray and then move on. Okay, shortness of breath over a few months. Okay, a chest x-ray. Again, I don't expect you to know how to read it. I'll just say it is abnormal, and you start to see these little nodular things. Okay, little nodular things all over, just all diffusely. Okay, kind of reticular, and there's like lines all over, more lines than you're used to on a regular chest x-ray. Reticular nodular interstitial opacities due to, I'm not sure. Okay, so what is the next test of choice? Okay, someone put TB, actually, could be, very well be TB. Okay. Okay, and so a few people put CT. Okay, someone put high resolution CT. That's correct. Okay, and a high resolution chest CT, basically, it's a chest CT just like anything else, but we do thin cuts, we do different maneuvers, expiration, inspiration views, and this shows the kind of nodular and reticular opacities. These are called tree and bud opacities. It's like these little branches and there's little nodular things coming off of it. Okay, and that is more specific for, I don't know if you can see. Okay, but basically I'll read it. It's diffuse tree and bud opacities. It's common in endobronchial infection. Specifically, you can see that with Mycobacterium avium intracellulae, MAI infections. Okay, and what tree and bud is a tree in bud. Okay, and these little buds that are going to bloom soon. Okay, and that's what this abnormality is seen. Okay, MAI is an infection. It's Mycobacterium avium intracellulae. Okay, so it's not TB per se, but it's in that family. Okay, so this is the CT, high resolution to characterize these things. It's good. Even if you got a regular CT, I think you can make the diagnosis just based on the diffuse abnormality. Okay, so abdominal pelvic imaging. So most acute abdominal pain in the ER setting, what study are you going to get? Just general, diffuse, really painful. What study would you get? Sorry, not being specific about. Okay. So some people said X-ray. Start with an X-ray. If you're thinking of bowel obstruction, something you can see, yes, you can start with an X-ray. Okay. A few people said CT. Okay, and that's not. Both answers are right depending on the situation. Okay, so most places, if it's not bowel obstruction and they're thinking, let's say it's appendicitis or something with kidneys, okay, you're going to get a CT with IV contrast. Okay, let's say if it's, I'm trying to narrow it down, let's say it's right upper quadrant pain and you're suspicious for cholecystitis. What study would you normally get? Good, a couple of you said ultrasound, okay, and that's correct. Okay, and so you know that based on your experience, but I think I want to tell you why. So ultrasound is sufficient. It's better actually at visualizing gallstones than the CT. Okay, and I'll show you pictures. It shows the wall thickening, surrounding fluid, and it's very important for sonographic Murphy sign. So you all probably know what Murphy sign is. You're pressing on the right upper quadrant, and the patient has pain there, but not nowhere else. Ultrasound is even more specific because you could take the ultrasound probe, go over see where the gallbladder is, and the sonographer can press down at the site, press down other places, and if the gallbladder itself, they're pressing down, and it's painful, that's sonographic Murphy sign. That's a very specific sign for acute cholecystitis. Okay? And that's why ultrasound, real time, you can see what you need to see for acute cholecystitis. Okay, if it's negative and you still think there's acute cholecystitis, let's say you forget that, you're just not sure. It's not specific, it's not cholecystitis, you're just getting you're wrong about your cholecystitis. Okay, well, you can get a CT, look for other causes. Maybe there's a bowel issue that an ultrasound cannot look for. Or if you think the ultrasound is equivocal for acute cholecystitis, you still really clinically suspect it, you can also get a HIDA scan, which is a nuclear medicine scan. I'm not going to go into what it is, but it's a test where you can, if all else being equivocal, you can get that test and it can tell you acute cholecystitis or not. Okay. Okay, I don't know if you can see over that wording, but acute obstructive uropathy due to renal calculi. Sorry, I already give you the answer. It's non-contrast CT. Okay, and so here are the kidneys, and this little bright spot is a tiny little stone. Okay, now the reason you don't get with contrast is contrast lights everything up. Okay, so the kidneys would light up. Okay, and you would not be able to see that little tiny stone here. Okay, it would be obscured by the contrast. Okay, so try to find, you can probably see maybe bigger stones and maybe obstructing stones. This little thing is probably not obstructing, but you would miss evaluation for the extent of the number of stones. Okay, so does that make sense why you would need a non-contrast study? Okay, yes, okay. So hematuria. Causes, I'll just list a number. If you just think about everything from the urinary system down, like we talked about kidney stones, is there a mass in the kidney, is there a mass in the ureter, is there a mass in the bladder? Sometimes prostatomegaly can also cause hematuria. Okay, and so is there one test that can get everything? And what would that test be? Okay, so a few of you are in the right ballpark. It is a CT, okay, and it's a specific type of CT, a CTangiogram. Okay, so basically of the abdomen, pelvis, not just the pelvis, goes all from kidneys all the way down to the bladder. And it's a urogram. It's specifically meant to evaluate hematuria, and I'll show you an example of that. I put a little star here of bladder masses. It's not well evaluated by CT. Okay, you will need urine cytology or a cystoscope looking at the bladder, and I'll show you one. Okay, so what a CTangiogram is here. First, a non-contrast study. Remember, looking for the calculi. Okay, and then a renal phase where the kidneys enhance, and an excretory phase. Sometimes people combine that, but an excretory phase is that the contrast is being excreted by the kidneys. Okay, so that's why you get this bright stuff in the renal collecting system and then down the ureters, and we're looking for filling defects, like a mass that prevents contrast, just like a pulmonary embolism where you have that filling defect. We're looking for filling defects in the ureters, mass-like thing. Okay. The reason, okay, and this is the coronal. Here's the kidneys excreting contrast. You can see the squiggly ureter going down. Here's the left renal collecting system. I didn't give you all the images, but this is representation. Okay, so the reason bladder cancer is sometimes not well thing, and this is true for CT for all distensible structures. A bladder is distensible. Obviously, you can feel it or it's collapsed, and mucosal lesions on the surface. Sometimes you can miss them. Okay, if the bladder's collapsed, you won't be able to see it on CT. If it's tiny little superficial mucosal thing, you want to be able to see it directly with the scope. Okay, and that applies for all distensible structures, including the bowel, and that's why we do colonoscopy or we do an upper scope, looking at for mucosal lesions that we may not be able to see on CT or MRI or any imaging modality. Okay, so here's a 30-year-old. He was apparently very hungry. This is the actual patient that I had. This was actually Thanksgiving. Swallowed a large piece of turkey without chewing. It got stuck. He tried to bring it up by inducing vomiting, and he was able to bring it up, but he had persistent, really bad chest pain. Okay, so what do you need to exclude? He came to the ER. What do you need to exclude? Okay, perforation, tear, something wrong with the esophagus, rupture, perfect. Okay, and how would you do that? What's radiologic study? Okay, some sort of swallow, gastrograph and swallow, good. And I think Kathy made a great X-ray and then something else. Great, I think you were listening. We're excluding esophageal tear. Let's start with an X-ray, okay? Because what we can look for is anything in the chest, mediastinal air, okay? So then you can get the gastrograph and swallow or esophagram, okay? Okay, well, let me bypass that to show you an X-ray. And here is air in the neck. Here, these black streaks, okay? And there's air surrounding the heart here, okay? Surrounding the heart here, okay? Arrows, okay? So this is pneumomediastinum, okay? And so in this patient, in this setting, I know there's an esophageal tear, okay? There's some, bowel perforation. There's air in the chest, okay? So then I know I have to see it. I can't just let it go, okay? Pneumomediastinum. Okay, so we do the gastrograph and swallow, and I'll tell you the difference between gastrograph and barium later. Okay, so here is the distal esophagus. Here it goes into the stomach, and it's spilling out. Okay, all the contrast is up all over, outside the bowel. Okay, so this is obviously rupture or tear, whatever you want to call it. I don't even know how to pronounce it. Boerhaave syndrome. You don't need to know that, but basically it was a rupture there. Okay, so what do you do with a patient with rising bilirubin? You suspect there's a biliary obstruction. What test would you order? Okay, so a number of you mentioned ERCP. Okay, probably not the first line test, and I'll go through the progression. Okay, so someone was correct. Ultrasound is the first abdomen ultrasound, and ultrasound is good. Again, it shows you gallstones, which a lot of times is very much the cause of biliary obstruction. You can look at the common bile duct and there's dilatation. But ultrasound, you can't really see the distal common bile duct. Again, it's centrally located. There's lots of bile gas. Oftentimes, you can't see that far. Okay, so at least the ultrasound told me that there is biliary obstruction, or at least there's biliary dilatation, which makes me think in acute setting there's some blockage, especially in a patient with rising bilirubin. Now, what do you do? Okay, so your options are ERCP or MRCP. Okay, ERCP, endoscopic retrograde cholangiopancreat. I don't even want to say it, but basically it's a GI procedure. They scope, and they put a scope down the patient's throat, down the esophagus to the stomach, to duodenum, to where the opening for the bile ducts is, and they inject, and they can do, the benefit is that you can treat the patient right there, remove the stone. Obviously, it's a procedure risk. Okay? And so nowadays, a lot of GI people are hesitant to just jump to that. They want to know what is going on before. Okay? And so MRCP is a test. It's a type of MRI, and its main focus is on the bile ducts, okay, and the pancreatic duct. And it's a non-invasive test. We don't have to inject anything. We just do an MRI scan, and you can look at the bile ducts as well as it's an MRI. You can see surrounding structures. Okay, so a lot of times the GI will want this before they go for ERCP. Here is an MRCP. Okay, I know it's a little grainy, but this is a patient. Imagine the patient is looking at you. This is the patient's right side, the left side, this is the patient's stomach. Okay, this is actually the gallbladder, and then the bile ducts, the right system, left system, draining common bile duct, and you follow, this is the cystic duct, you follow here, oh, there's this filling defect. There's a large stone that's blocking the common bile duct. Okay, it's choledocholithiasis. Okay, so now with that information, they took them, GI took them, they put the scope through the stomach. This is the second portion of duodenum. They injected the major papilla, and they inject it upward, and you can't really see it, but there's this little loosened thing here. That is that stone that we saw on MRCP. So now they can go in, get a basket, and then basically pull it down out. Okay, so that's ERCP. Okay, vascular imaging. Okay, so this has parallels with the neurovascular imaging that we were talking about. So patient with a smoker, peripheral vascular disease, acute onset left cold foot. What are your options for imaging? And as you're answering, I'll just kind of go through the progression. Well, X-ray, well, it's not going to look at the, the vessels. Okay. Ultrasound Doppler, okay, it can look at the vessels, it can look at the vessels, but it may not see collateral vessels. It may not be subtle stenoses, and particularly when you get down closer to the foot, leg, they're really hard to see by ultrasound. CTangio is a good study. Okay, I think people forgot to answer one more, another imaging modality besides CT. We talked about for neuro. The old school angiogram, conventional angiogram, great. Okay. And then the MR angiogram. Okay, so ultrasound can potentially see stenoses, occlusions, but it's not really used in the acute setting. Okay, it's hard to see collateral vessels. Like I see an occlusion. Does that mean it's a acute occlusion, a chronic occlusion? Because if it's a chronic, there'd be collateral vessels that develop around, and ultrasound can't really, it's hard for you to pinpoint the anatomy to see whether it's collateral vessels or not. Okay, so ultrasound not really used in the acute setting. Okay, CTA runoff, basically of the aorta down to the foot if you want, and that is usually the main test of choice for pre-surgical or interventional planning. Again, just like with all the other interventions, they want, whether it's vascular surgery or interventionally perform the actual procedure, they want to know what they're getting into. Okay, so CTA, again, is a great study, and I think it's first-line choice. MRA runoff, okay, you can use contrast with MRI. It's generally of a poor quality for smaller vessels. Remember, we talked about MRI has lower resolution. It's probably fine for the aorta and the iliac vessels, but let's say you get down to the lower leg. These small little vessels, it's pretty poor quality when you talk about MRI. Okay, so really CTA with contrast, that's the one you want to do first line, okay? Especially with the cold foot, acute cold foot setting. Conventional, someone mentioned angiogram, old school conventional, can be done if they already know that they want to do surgery and plan for it. Obviously, you're doing the procedure at that point. Okay, so here is a CTA runoff. This is the common femoral arteries here. Okay, and to spare you all the axial images, this is a 3D reconstruction. Here's the aorta. iliacs, common femoral down all the way. So to give you a little bit of anatomy, this is a reconstruction of that pelvis all the way down to the foot, if you want it. Okay, and so a little more focused. This is the aorta with the renal arteries here, iliacs, kind of coming down the leg, just to give you anatomy there. Okay, and here is the stenosis. Okay, that's the popliteal artery. Okay, and bone, so you can actually see the stenosis here compared to a normal side here. Okay, so very exquisite detail for CTA to see where the level of stenosis is. Okay, so this is a CT venogram. This is not a CT angiogram. And again, this is imaging of the IVC, and it's a different time. It's a more delayed phase than the arterial, and we can see this filling defect in the IVC. Okay. Okay, so other head and neck imaging. Let's look at, for sinus disease, you can order a CT paranasal sinus. For potential sinus surgery, you don't want to order that for your general, most people, if they have sinusitis, they just give them antibiotics, treat it presumptively, okay, if they have the sinus symptoms, okay. CT really reserved for people who have had chronic and it doesn't resolve and it's, they're thinking surgery at that point. And then you want CT for the bone detail, okay. CT soft tissue neck, you can also get an MR soft tissue neck, they're both good, okay. Acute settings, you maybe, for abscess, you want to get a CT, like we've talked about. Temporal bone, exquisite bone detail for the temporal bone, for auditory structures, for trauma, things like that, okay. CT of the orbits, mainly for trauma. MRI for the orbits, looking at the soft tissue, let's say for optic neuritis, you're looking at the optic nerve, looking for signal change there. Okay, again, trauma, there's the theme of CT is your mainstay for trauma. Everything else, MR, brachial plug, looking for nerve injuries, MR. Okay, so hopefully that can, that kind of categorizes how you think about what you order. Okay. And so take-home points for this part of the lecture. There's a whole diversity of radiologic studies, X-ray, fluoro. I'll show you more cases on the next lecture, ultrasound, CT, MRI, nuclear medicine, and intervention. And I'm just kind of giving you a taste to see when you use different things and what things are good for. There's all new evolving applications like technology, and there's specific factors. In the next lecture, we'll get to that. Like, what if my patient has this? Well, what do I do? It prevents them from getting a CT, or let's say a patient has a pacemaker that MRI is not compatible with. I can't get an MRI. What do I do? Okay, so those are more kind of second level understanding, and you'll have to know. But by understanding the different factors of different modalities, what their advantages and disadvantages are, you can kind of understand why this might be a second line study. Okay. You have to think about also, back to this point, is availability. Like, let's say the MRI scanner is not available, or patient think about cost and time limit. How quick do I need to know? Okay, again, consult the radiologist if you have questions. Okay, so for now, let's take a 5-minute break. So right now it's 2:45, and we'll meet back at 2:50, and we'll go from there.